welcome to my YouTube channel Ayurveda Basking. So today video is very special and very important. It is one of the most weighted video, and in this video we will discuss our Roga Nidana practical exam with our all Viva portion, and this all are according to our NCISM pattern that is given in our syllabus. And in this video we will cover all those important points since this practical constitutes 200 marks. So in this video we are going to cover our 200 marks, and our target will be we can get at least 150 plus marks in our Viva. So let's start our video. First of all, there are 5 main heading that is coming in the Roga Nidana exam. I will write here. First there will be sporting. Okay, so 6 main headings are there in sporting, and it constitutes your 30 marks examination. Then second is you have a long case that constitutes 40 marks. In that long case basically 3 main things are there. First you have to take proper history, means like chief complaint, history of past illness, history of present illness, all those things. Second part, you have to do the examination of that particular affected system or srotas. And the third part is the differential diagnosis along with the confirmation diagnosis. Third heading is your basically the demonstration of a short case that constitutes the 30 marks. You have given any case or short topic that you have to do the demonstration. It may be from the respiratory system, locomotor system, CNS, integumentary system. So all those, out of them you have to perform the given examination. And the next portion is, and your next portion, fourth portion, is your Viva, and here the Viva is for the 70 marks. Okay, so in Viva also we will see which type of question and what the area that is asked given for the Viva question. And in that Viva, on the record activity book is there that constitute 10 marks, and the last is your internal assessment that you already got 30 marks. So this is the whole pattern that is happening in our Nidana paper, Nidana practical exam. And in this video we will cover all this important heading. Along with that I have written some important point. Maybe the same thing can come in the exam, or same thing but some modification can be asked. Okay, so let's start our discussion through the first point, that is spotting. Okay, in this spotting, as you see I have written here, so in spotting there are 10 questions are there, and one question will be of 3 marks. Okay, so 30 marks portion we are covering first of all. And in this spotting basically 6 main heading are there, and we will see those 6 main heading first. First is the X-ray, and these are the heading: X-ray, ECG, clinical sign picture. And in this video you will see maximum, I will try to show you maximum clinical sign with their picture that can come in exam. Then slide of pathology slide, some of the patho slide I will share in this PPT, and the full PDF of those things will be uploaded on the Telegram itself. Fifth one is the diagnostic reports. Okay, in diagnostic reports basically TFT, LFT, their hemogram are, that also we will see in this video and try to learn today itself. And the last thing is the causative factor. Causative factor generally from our Nidana paper 2, like shloka heading, and they may be like Aharaja Nidana, Viharaja Nidana, or any specific Nidana can be given. In that basically specific in portion, when you're doing your practical, there will be some images are kept, and you have to understand which disease is it and which are the diagnosis, which are the investigation you will prefer for this disease confirmation, and what is the differential diagnosis, all those things. Okay, so first of all we will start with this X-ray. So in this X-ray actually there are 2 main heading you have to cover. First of all, if you have given one X-ray, then you have to know this X-ray film is technically adequate or not. For that there are majorly 4 key heading, and you can remember it with your RIPE. This is one of the trick. Okay, RIPE means, R means rotation, I means inspiration, P means position or projection, and E for exposure. Okay, so R what denote? R means the medial end of your clavicle are equidistant from the vertebral spine. For example, if it is your vertebral spine, if this is your vertebral spine, then this clavicle should be equal distance from the medial end. Second point means if one clavicle is closer, then the patient is rotated toward that side. And I will show you one image also. See in this image, Here first image, the patient is no patient rotation, so medial end is equidistant. Same here, same here. So equal distance of the clavicle to the this midline of the spinous process. But in second image you can see here patient is rotated because this medial end is somewhat not equidistant. Okay, so first of all you have to check the rotation. Second one is the inspiration. A good inspiratory effort is confirmed if 5 to 6 anterior rib or 10th posterior rib are visible above the dome of the right diaphragm. If a person is in a poor inspiration, then it will make his or her heart look like an enlarged thing. Okay, third thing is the position. Position actually give you you have that particular x-ray, it is a PA or a AP view. Okay, so if we talk about the chest x-ray, and like maximum chances are there may be the chest x-ray. Different conditions you have to know about this. PA view, scapula are usually rotated out of the lung field and a heart size is more accurate. Okay, and the last and the third portion is the exposure or penetration. It will give actually the well exposed film. The lower thoracic vertebra should be faintly visible. And if it is under penetrated, so there will be two conditions. If it is under penetrated or over penetrated. In under penetrated, image appear white, so detail behind the heart lost. Okay, but if it is over penetrated, then image become very much dark and lungs become burnt out, like blackish color. Artifact means if there is any external object. Okay, maybe it's ECG leads, it may be a jewelry, it may be then internal device, like some people have a pacemaker, artificial pacemaker, so all those things. So here you can see this is a normal chest x-ray. This is the clavicle. This is your great vessels along with your heart. This is your diaphragm. This is your stomach on left side, and this is liver on the right side. Okay, and here also like every portion you can see clearly marked in second diagram. This you can see is your manubrium, sternum part. Then this is your superior vena cava. Then your right main bronchus, horizontal fissure, right atrium. Then this is your inferior vena cava. This is your diaphragm. Next, this is your aortic arc. This is your pulmonary trunk, left main bronchus, left ventricle, oblique fissure. So these are the like things we can see by our chest x-ray. As you see here, the same thing is explained. Next, second heading is what we have to comment on and what we have to fight. So basically these all are the heading that is mentioned. Find out the abnormal finding or sign that indicate airway, bone or soft tissue, cardiac, diaphragm, effusion, gastric bubble or hyla mediastinum. Okay, so first category is airway. Basically in airway what we have to look the trachea position, carina and bronchi, and what will the potential sign. It may cause, there may be a deviation or there will be extension, there may be any mass, pneumothorax or like tumors growth will be there. Second portion is bone or soft tissue. Here we have to see our ribs, clavicle, scapula, chest wall, which all the bone you can see through that particular x-ray, and specifically we are talking about chest x-ray, to ribs, clavicle, scapula and all. And here we have to appreciate the fracture, lytic lesions, maybe particularly the CA growths, surgical cliffs. Third one is the cardiac portion. We have to see our heart size, that is cardiothoracic ratio should be less than 0.5 in PA view, and we have to we have to inquire about the if it is an enlarged heart size, CHF, maybe the complications, and water bottle shape like conditions. Fourth one is your diaphragm. You have to check the shape, height and costophrenic angle. And what will be the potential signs? Flattened in COPD, burnt angle in pleural effusion, air under is seen in the bowel perforations. Then next is the effusion. If fluid is at the lung base, so it will cause meniscus sign, curved upper edges of the fluid at costophrenic angle. Then then comes the gastric bubbles. In gastric bubble what happen? Air bubbles under the left hemidiaphragm, and it may be absence or displacement due to the distal hernia or diaphragmatic injury. And the last portion is hyla or mediastinum. So there may be a hyla density or mediastinum width. So it will indicate hilum overlay sign that differentiate hilum masses from the heart masses. So here in this PPT I will giving you some of the key x-rays with their diagnosis. Okay, so first of all we have to see what is the normal appearance. This is one of the normal, and here mark area is, for example, one area is this that denote the aortic arc, 2 is your pulmonary trunk, 3 is your left atrial appendages, 4 is your left ventricle, then 5 is your right ventricle, 6 is your superior vena cava, 7 is your right diaphragm, 8 is your left hemidiaphragm, and 9 is your horizontal fissure. So this is the normal PA view of chest x-ray. Then what is the Sill-Housed sign? Actually in Sill-Housed sign there will be a loss of the border, we know that this is particular, this is our particular heart border that's separating the lungs from the heart, but actually what happening here, we can't differentiate or distinct the border of the hearts, so that's known as the Sill-Housed sign. Okay, then here you can see this is normal lung physiology. This is your trachea, then aortic arc, left hilum, pulmonary artery, left atrium, left ventricle. This is your costophrenic angle. This is your this is a cardiophrenic angle, and this is your costophrenic angle. Then comes the actually what happen in pathological state. Normally our lungs have a air, okay, so much air there. So in pathology what happened, this air is replaced by some pathological process, maybe pus is there, maybe anything like pus, fluid discharge, all those things will be filled there, and according to the injury tissue react. Okay, and lung injury may be generalized or may be localized, maybe it's a to a particular lobe or generalized. Then this is the consolidation. Actually consolidation, what is happening, here the picture is for the lobar consolidation. The air is replaced by fluid, pus or blood. Okay, and the airway is patent, and one of the key feature of consolidation is the air bronchogram. Okay, next one, these are some of the case. For example, this first case, here you can see easily the clavicle. This is your spinal process. Okay, this is your heart area, this is your aortic arc, this your diaphragm. Okay, but here you can see, I will mark with different color, one object you can see here. Okay, so, and this is on the left side, so this same thing you have to write. A single 3 cm relatively thin walled cavity is noted on the left mid lung, and this finding is most typically of the squamous cell carcinoma, and the 1/3 of SCC mass show the cavitation. Okay, so this is a CA case. Next comes the, here you can see the chest x-ray. All we can appreciate it, but still we can't differentiate the heart borders and all. So loss of the heart borders, that is Sill-Housed, notice over the inflation or unaffected lungs आपके unaffected हैं. Next you can see here you can see opacity. Okay, or cloudy appearance, means generally which portion should be white, that which portion should be generally black, that become white. So cloudy appearance, whitish appearance, and that see in the pneumonia cases. So this is a chest x-ray of a pneumonia patient. Next, this is not that much important. Then here in tuberculosis, what happened, due to that healing and regeneration process, scar started developing. Okay, so you can see here this fibrous scar. So that is a typical presentation of a tuberculosis patient. Next, this is a COPD patient, where what happened, increase in the heart diameter, flattening of the diaphragm, and increase in the size of the retrosternal air space. Then these are not that much important because they are so much complicated case actually. Next come the this is pneumothorax case, complete lobar collapse, and so this all is about the X-ray. Next heading, second heading, is about the ECG. So now we will discuss about the ECG and all. Okay, so in ECG also there are basically 5 or 4 headings. Like first we have to comment on the rate or rhythm, then P wave, T wave, PR interval, and QRS complex. These are the some of the main heading we have to comment on. And here I have added one picture in that we just first thoroughly revise this ECG. Okay, so actually ECG, what happened, this is one of the wave graph seen. There is a wave P, then Q, then your R, S, T. Okay, so P wave is actually showing the electrical activity of the upper right atrium, upper atrium of the heart, and it usually appears as a smooth rounded wave and followed by a flat line indicating the pulse has moved to the lower heart chamber. So actually is what happening. So P wave is generally your contraction of the atrium, and after that a smooth line is there that indicate that the pulse is going from atrium to ventricle. Next come this QRS complex. QRS complex consists of a downstroke Q wave along with the upstroke, means uphealing, of R wave and a downstroke S wave. Together they represent the ventricular depolarization, and it take for the electrical activity that travel through the lower chambers of the heart. Not every QRS complex will show all the 3 wave. Okay, and after that comes the T wave. T wave represent the ventricular repolarization. Okay, so there are atrial contraction that constitute for P wave, ventricular contraction that is for QRS complex, and ventricular relaxation that is T wave, but there is a no wave for the atrium relaxation. Okay, it usually appear in a asymmetrical pattern with the peak closer to the end. So as you can see, this peak is peak is toward the end of the T wave. Okay, so here you can see one important things come, that PR interval, the interval between the P and the R, these things. Okay, so PR interval begin at the P wave and end at the start of the QRS complex. Then it measure the time take for electrical activity to travel from upper chamber to the lower chamber of the heart. So this is one of the important things you have to remember, that this actually represent the time travel for electrical activity to travel from the upper chambers to the lower chambers. Okay, so here also these segments are shown as you can see. Next, this is the waveform neatly as you can see. This is our P wave, then QRS complex, and T wave. P wave represent your atrial depolarization, QRS for ventricular depolarization, T for ventricular repolarization. Okay, next is what is an ECG. So basically ECG is an electrocardiogram that is record the electrical activity of your heart, and it show how fast your heart is beating and whether it is rhythmic or not rhythmic. Rhythmic is normal, non-rhythmic is not normal. Then basic part is P wave, atrial contract, QRS is lower chamber contract, T wave is ventricular relax. Then what will the common finding of ECG? So normally there will be a regular rhythm, regular rate, and normal wave. Fast heartbeat is known as tachycardia, where heart rate exceed 100 per minute. Slow heart rate is bradycardia, where heart rate is less than 60 minutes. So generally normal considered 60 to 100. Irregular rhythm is the unequal spacing between the beats. Heart block is problem in the electrical conduction due to the blockage of that particular part. Heart attack is the ST elevation or depression, that known as STEMI or non-STEMI heart MI, and abnormal Q wave. So simple ECG interpretations basically: check your heart rate, fast, slow or normal, check your rhythm, rhythmic or non-rhythmic, look at the P wave present or absent, look for QRS narrow or wide, check ST segment, T wave normal or abnormal. And then these are some of the thing we have to know as a basis. Like sometime we have given one ECG and we have to calculate the heart rate. So there are different method for this, and all I have enumerated here. First method is the big box method, that is most common one. Okay, so first of all you have to take 2R, this P Q R S T. okay, यहाँ पीछे से यहाँ see, this is the R wave. So you have to take the big box between the two consecutive R wave, and then you have to count that big square. Okay, after that counting the big square, you have to divide it with the 300. For example, 300 divided by, if you between 2 R, if 6 box are coming, then divide by 6. If 5 are coming, divide by 5. This is the first method. Second method is the 6-second method. Okay, so first you have to count the QRS complex in the 6 second. In 6 second, how many QRS complex are there? Then for example, if there are 8 QRS complex in 6 second, then multiply it by 10. It's also known as a rule of 10. Okay, so normal value generally is 60 to 100 per minute. PR interval takes 0.1 to 0.2 second. Okay, and QRS duration generally less than 0.12 second. So this all are there. This is your P wave, then this is your R. So this you have to calculate interval between R and R. Okay, then this is your ST interval, this is your TP interval. Then in our syllabus heading what is given, that point we will discuss now. So first point is rate and rhythm. First you have to check the rate. If you are saying that particular ECG is rhythmic, means there will be a regular interval or regular boxes between R and R interval. And regular rhythmic, each QRS preceded by the P wave, and P wave is upright in the second lead. Okay, then this is the method. You can divide it. If you are counting, for example, two methods are there. If you are taking the big square, then divide it by 300. If you are taking the small square, then divide it by 1500. Same result will be coming in both the method. Okay, second heading is the P wave interpretation. So first of all, what is the location of P wave? It should be before the each QRS complex. This is the second heading of our syllabus. First we have to rate and rhythm, second is the P wave. So P wave should be coming before the QRS complex, and its amplitude is generally less than and equal to 2.5 millimeter or 0.25 millivolt in lead 2. Okay, and this duration is less than or equal to 0.12 second in 3 small square. Then configuration, it is a smooth and rounded like this, it is there, and it's a single peak. Deflection, upright in the lead, inverted in AVR. Comment is, you have to say like P wave is present, uniform, upright in lead 2, like this you have to comment. Third portion is PR interval interpretation. So PR is generally begin with the P wave and beginning of the QRS complex. So in between of these two coming your PR interval. Its duration is 0.1 to 0.2 second. Abnormality, it can be short in pre-excitement and it may be prolonged in the primary atrioventricular block. Then comment example, PR interval is dash second, you have to comment, and it's normal, prolonged or shortened. Here I have it one image. This is first image of the normal atrioventricular impulse transmission. Second is the first degree AV block. Third one is the pre-excitation. Okay, so here normal PR interval there, that constitutes 0.1 to 0.22 second. Second one, it is a somewhat prolonged, as you can see. So here it is happening in the first degree AV block, and third, when it is a short, it is happening generally in the pre-excitement conditions. Okay, fourth thing is we have to comment is on the QRS complex. So QRS complex is its location is immediately follow the PR interval. Its amplitude is, if you are checking through the limb lead, it having less than and equal to 20 mm. Chest lead is less than or equal to 30 mm. Duration is generally less than or equal to 0.12 second. Configuration, it is sharp or narrow, no touching unless bundle branch block. Then Fourth point is the ST segment interpretations. So ST segment is very important in case of MI cases, okay. And its location, if you talk about, its start of the end of the QRS and beginning of the T wave, okay. Normally it is isoelectric, but maybe elevation or maybe depression is there, so that could lead to the non-STEMI or STEMI MI conditions. Sixth and the last interpretation in ECG is the T wave interpretation. So its location is follow the ST segment and its amplitude is written here, okay. And next, third heading in spotting will come your clinical sign, okay. There are actually so many clinical signs in our modern medicines, but some of the important I have listed here. Let's see all those clinical signs. So these are the some signs that are clinically important. First one is the air crescent sign, that is classically in the aspergillomas, okay. As you see here, air crescent sign, and sickle cell lunacy partially surrounded by a mass in the pulmonary cavity is seen on X-ray or CT scan. Next one is the angel wings or bat wing sign, and like appearance of this kind of bat that's seen in the pulmonary edema, which involve the perihilar regions and spare the cortex of the lungs. Next one is the anterior nose sign. As you see here, anterior nose sign like this, and this is on the lateral view of the foot, elongated anterior superior process of calcaneus seen in the dorsal. Next comes the apple core sign. As you see here, apple core sign, this is basically seen in the carcinoma of the bowel and usually the colon from the circumferential involvement of the lumen. Bamboo spine, this is important, can come. This is seen in the AS, ankylosing spondylitis. As you see, like bamboo, appearance of your vertebral column, and there will be the syndesmophytes fusing of the vertebra. Next comes the beveled edge appearance, and that typically seen in the eosinophilic granulomas. Next comes the this blade of the grass skin sign, advancing a wedges shaped osteolytic margin of the active seen in the Paget disease of the bone, seen in the diaphysium, as you see here. Next comes the birds of the prey sign, tapered barium column seen in the sigmoid, that is not that much important. Then bird's beak sign, then bowler's head sign. I will upload this PPT, you can check all this sign. This boot shaped heart, box shaped heart, these are the like anomaly that happen, but they are so much typical, so chances are lesses. Like most commonly used sign may be coming. This can come, this is important. So I will give you one trick how we can remember this, okay. And this both are happening in the RA, okay. First is your swan neck. So first thing you have to remember, this swan neck always happen in the index finger, okay. Let's suppose this is your index finger. So what happening, this is known as the distal interphalangeal joint, this is known as the proximal interphalangeal joint, okay. Flexion, as you see here happening, the flexion here is extension, but that is a thoroughly extended to hyperextension. So in swan neck, but what is happening, there will be the flexion of the DIP and hyperextension of the PIP, okay. Next comes this bottom-nail deformity, and this bottom-nail deformity is happening in the ring finger and middle finger, okay. And it is just opposite to this, you have to just interchange. For example, here what is happening, DIP flexion in the swan neck, but in bottom neck what is happening, extension will be there in the DIP, okay. So hyperextension of the DIP joint and flexion of the PIP joint, and that particularly seen in the rheumatoid arthritis. Next is the colon cut off sign. As you see here, this is your stomach, this is your colon cut sign, that's seen in the acute pancreatitis. Next comes the Carmen meniscus signs. Meniscus is formed and that is a suggestive of a malignancy. Okay. Next is this cotton wool appearance and coffee bean sign. This PPT I will share. You can see all this appear like things, and some other that is not here that I will share in the Telegram channel. Okay, this is champagne glass, that's in the achondroplasia, pelvic inlet. Next, this diaphragmatic sign, corkscrew esophagus, cochlear signs, codfish vertebra, David Letterman's, double bubble sign, deep sulcus sign, drooping lily sign, dripping candle wax sign, then dagger signs, egg shell calcifications, egg on the string sign, fallen fragment sign, fig tree sign. Next, football sign, fish cooking of ureter, fish mouthing of vertebra, golden sign, glowed finger sign, gull wing sign, hair and sign, heel and pair sign, Honda sign. They are actually not that much important. All are not that much important. The most important, like which disease you have studied in your syllabus, you just study at least those sign. Okay, this honeycomb of the lungs, it is important, and it is says in the cystic fibrosis. Okay, this is important one. Next is this ivory vertebra, then J-shaped shella, and it is seen in the optic chiasma glioma, lead pipe colon sign, licked candy, Mercedes-Benz sign, Napoleon hat sign, oil droplet sign, pear-shaped bladder, picture framing vertebra, pseudo tumors, putty kidney, Rugger jersey spine, rat bite sign, rice grain calcification, snowman heart sign, then swan neck. This is important. Then silver fork deformity. Okay, snowstorm appearance. This is important, and it is basically in the metastatic CA from the thyroid. String sign, step ladder appearance. Then sunburst sign. This is also important. It's in the osteosarcomas. Salt and Peter skull. This is also important. Hyperparathyroid में. And next comes your thumbprint sign. Thumbprint sign is not that much important. Then comes the thumb sign and water bottle heart sign. It is also important, as you see, like this, and this is seen in the pericardial effusion. I will share this PPT on the Telegram channel, so you can see all this sign, but the most important sign are those which is disease we have studied in our second year syllabus. Okay, some other signs are there like Cullen sign and all, that I will share the picture on the Telegram channel. Next come some of the sign I have written here also. First is clubbing of sign, that is very common. Okay, clubbing of finger is basically identified by the bulbous enlargement of this distal phalanges, and possible etiology may be the lung cancer can be the reason. Bronchoectasis, this is permanent dilatation of bronchioles. Then cyanotic congenital heart diseases, infective endocarditis, inflammatory bowel diseases, and liver cirrhosis. Investigation, like when you are given any sign, and to this all heading you have to give answer. Like any of this they can ask. Identify the sign, possible etiology, possible investigation, differential diagnosis, or diagnosis the condition or disease associated with the sign. So here is one of the trick you can remember for clubbing. What is the here this trick is for how we can correlate in which disease clubbing is happening. It can happen in cyanotic heart diseases or cystic fibrosis. It can happen in the lung cancer or lung abscesses. It can happen in ulcerative colitis. It can happen in the bronchoectasis. It can happen in the benign mesothelioma. It can happen is infective endocarditis or idiopathic pulmonary fibrosis, and for neurogenic tumors, and G for gastrointestinal disease like Crohn's disease. Okay, second is jaundice. As you know, jaundice means the yellow discoloration of the sclera, skin and mucous membrane. So possible etiology may be it's the jaundice may be prehepatic, posthepatic or hepatic, and the reason is vary. For example, prehepatic is mainly due to the hemolytic anemia, hepatic due to the viral hepatitis or cirrhosis of the liver, Post hepatic is due to gallstone or pancreatic cancer. Investigation, we have to do the liver function test, ultrasound, abdomen, and viral hepatitis marker. Differential diagnosis, carotenema, drug induced hyperbilirubinemia, or diagnosis is hepatobiliary disease. So here this is one of the picture of a jaundice person, and this is the cause and the symptom written here. Next one is cyanosis. Cyanosis means a bluish discoloration, as you see in the picture, bluish discoloration of the lips, then maybe the bluish discoloration of fingernails or creases of your finger. Then possible etiologies may be the congenital heart diseases, COPD, severe pneumonia, pulmonary embolism, and the possible investigation is the pulse oximetry, then arterial blood gas, chest x-ray, and echocardiography. Next comes this goiter. As you see, goiter is basically enlargement of your thyroid gland. This is the condition, and but with the possible etiology, iodine deficiency, grave disease, Hashimoto, that is autoimmune, multinodular goiter, and investigation may be the thyroid function test, thyroid ultrasound, thyroid antibodies, FNAC if nodule present. Next comes the koinocynia. Actually this is the happening in the iron deficiency anemia, in which what happen, your nail becomes spoon shaped, as you see here. Okay, fourth things is coming the slide, and here some of the thing is mentioned, like hematology, histopathology, stool microscopy, urine microscopy, microbiology, parasitology. Out of this, any one slide will be there, and you have to give that particular answer. Like first you have to identify the that slide, and then you have to give the provisional diagnosis, like that particular condition happening in when. Okay, so for this I will upload one PPT on our Telegram channel. You can see that histopathology slide from there, and they are the most like important. For example, here they give the peripheral smear, so only that peripheral smear from the hematology. Like this, only limited slides are there, and you can easily cover that portion. Next comes the diagnostic report. This we'll study in this video. Okay, so this all are mentioned in our syllabus, and now we will see how we can remember this. Next comes this diagnostic tools. First comes for the hemogram. So hemogram, we have to see our blood related things. First is your hemoglobin. So hemoglobin actually is the protein in your blood that hold the oxygen. Okay, in men it should be 14 to 17 gram per dl, and women in 12 to 15 gram per dl is the normal range. Okay, WBC are your leukocyte and the cells of the immune system, and their normal number is 4500 to 10,000 cells per microliter. RBC, they carry the oxygen through your body, and they also help filter the carbon dioxide, and they are basically 14 to 17 men, and in women 12 to 15 per gram per dl. Then hemocrit is the volume percentage of the RBC, and it's normally 40% for the male and 31% for the woman. MCV is the average size of your red blood cell, that should be 80 to 95. Platelets is also known as the thrombocytes, and are a component of blood whose function is to be stop the bleeding by clumping or clotting, and this their number is generally 1,40,000 to 4,50,000 cells per mcl. And next come the ECR. We have to measure it through the Westergen method. And so next this ESR is actually help in to know the condition that cause the inflammation. In inflammation, ESR will be raised. In male it's 1 to 10 mm, and in female 5 to 15 mm. So these are the normal value. Whenever there is a change in normal value, then there will be any pathologies happening. Then next comes your liver function test, and this all are the things we have to check in LFT. First is your bilirubin total. So bilirubin is actually your reddish yellow pigment that made during the normal breakdown of the RBC, and its normal values like up to 1 milligram per dl. Then conjugated bilirubin is the direct bilirubin, is the more soluble and less toxic, and conjugated with the glucuronic acid is values 0 to 0.35 milligram per dl. Unconjugated is that is bound to certain protein in the blood, and its normal values 0.2 to 0.65. Okay, then comes your SGOT, AST, serum glutamatic oxaloacetic transamylase enzyme that is normally present in liver and the heart cell, and its normal value is 10 to 14 IU per liter. Then ALT is a serum glutamic pyruvic transaminase, that enzyme normally present in your liver and heart cell. Its normal value is also this, and these are the typical tests that we are doing for liver test. Then alkaline phosphatase is an enzyme found throughout your body. However, it tends to be more concentrated in liver, bile duct, bone and placenta, and its normal value is 40 to 112 mu per liter. Total protein is a biochemical test for measuring the total amount of the protein in the serum, and the protein in the serum is made of albumin and globulin. So its total amount should be 6 to 8.5 gram per liter. Then albumin, that is produced in the liver and form a large portion of all plasma protein, and its amount is 3.5 to 5 gram per liter. Then globulin is a group of protein in the blood and play an important role in the liver function. Its value is 2 to 3.5. So these are the normal value of all your liver enzyme, and if they are elevated or they are decreased, then there may be sure something happening to your liver, and liver is your important organ, so you should concern to doctor. Next is your kidney or LFT. Next your kidney or RFT, renal function test. First comes the, you can remember through BUN. Okay. For first is there is the blood urea. Urea is your terminal product of the protein metabolism. 1 gram of protein can produce 0.3 gram of urea, and the normal value is 10 to 15 milligram per dl. Serum creatine is a chemical waste product in the blood that passes through the kidney to be filtered and eliminated in the urine, and its normal is 0.6 to 1.1 milligram per dl in women and 0.7 to 1.3 milligram per dl in men. Serum uric acid, you just see all this value, and you have to actually remember their normal value, because whenever any, like for example, if you have any kidney function test report or LFT, RFT, then you have to see first of all they are in a normal. If they are elevated or decreased, then you have to write the pathology related with that particular organ. Okay, I will share this PPT on the Telegram. Then this is your lipid profile, that is also given in syllabus. You have to know your normal value. Generally what happens, cholesterol should be less than 200, triglyceride is up to 150, HDL should be up to 60, LDL should be less than 70, and VLDL should be less than 30. Then blood sugar level is also given in our syllabus. So blood sugar level is like a random blood sugar, fasting blood sugar, and glucose intolerance. So you should know this normal value, and this is pre-diabetic, that they are prone to the diabetic stage. Then this is for HbA1c. Urine test is not given, but you have to remember this thyroid function test, only these three value, T3, T4 and TSH. So we completed this heading. Next comes from the Ayurvedic portion. Okay, so this is the causative factor or hetu. In this sporting, what is happening, you have given some images. For example, like I have added through some images. This 4 images you have to given. A person is drinking more water, then dry meat, then madhya, and then this is a tilapishti. So we have to say which disease have this all nidana. So in our shloka we have studied ati ambupanat, then shushka amesam, this madhya, and this tilapishti are nidana of atisara. So you have to write atisara is the answer. So like this, any specific diet can be given, or any specific regimen should be given. For example, in Amavata we have studied viruddha ahara, viruddha cheshta, nichalasam or manda agniyata, specific nidana for the Amavata. So like this, some image are given and you have to identify, oh, these are the Amavata nidana. Then any specific factor, for example, this atisara also, krimi is mentioned as one of the nidana, and in kushta this puro janma karma or papam karambi or sadhu ninda is the differentiating nidanas that is mentioned for their disease manifestation. Next, second part is coming, that is very important part and very like kind of tough part, is your long case. Okay, so long case is basically, first of all you have to know it is for 40 marks. Okay, so you should prepare it very nicely, and it have three main heading. First is simple history, the normal history we are taking, chief complaint, then history of present illness, past illness, family history, treatment history, surgery history, then personal history. Second comes the examination of that particular system which the patient is suffering, and the third portion is the differential diagnosis. Out of this, examination constitute 20 marks, history constitute 10 marks, and differential diagnosis for 10 marks, and this total is 40 marks. Okay, for this actually we have written, I think, three cases in our Nidana record. So I will share my case on our Telegram channel. Who want that case as a reference can download from the Telegram. Okay, in that cases I have completed all this, mainly all headings. And if you want to make your paper presentation more good, then you can add some Ayurvedic point like dosha and all involvement. So these are the heading that I have highlighted. For example, the basic personal patient details, chief complaint, history, past illness, family, treatment, and person and all. Then in examination part, there are two examinations. First is your general examination, in which you have to do your general examination that we are doing. Then you have to include your asthasthana pariksha, and also in systemic examination you have to do the pancha indriya, along with that your system involved, srotas involved, and here it is mentioned mana pariksha, sattva pariksha. Next comes the, you have to comment on this, and if there is a specific investigation mentioned, then you have to write, or you have to write the interpretation of that also. Third portion coming the differential diagnosis. In differential diagnosis, two things are there. One is the differential diagnosis, that is Vyavachedaka Nidana. Second is the confirmed diagnosis, that is Vyadhi Vinasham. So you have to write both things. Then you have to eliminate, or like you have to take out of this differential Nidana, this is the main like disease, main provisional diagnosis. Then you have to justify that answer, and you have to come to a final diagnosis, and the whole samprapti you have to write, including the dosha, dusha, indriya, manas, agni, koshta, sroto, dushti, udbhav sthana, sanchara sthana, rog, marga, udbhav, and arishta. Okay, so this I will upload on Telegram. Third heading is basically the demonstration. Okay, this is also important part, and this is so big part, and still it is only for 30 marks. So actually what is happening in there, you have given a specific case scenario, or you have to examine on a patient or maybe the student. These are the system can be given. For example, in respiratory system they can give you perform percussion, or maybe the auscultation, like that. Okay, auscultation in here, cardiovascular. Then in oral cavity and per abdominal examination, nervous system, so many things there, cranial nerve, important part. Then sensory system, then your reflexes, power, tone, bulk, those, like these are the key heading that can be asked: tone, power, bulk. Then some tests are also mentioned that you have to focus on that also. Locomotor system is mainly all joint are very important. Along with that special test that is mentioned, knee joint is very important, ankle and all, and integumentary system also, like general what we are doing, and special tests are also there in integumentary. So these are the heading you should cover. If you are lucky, out of this they can ask, and if you are not lucky, they can ask like anything, because there are so many things in examination. And first of all, you have to approach a patient very nicely. And the last heading is our Viva. Okay, and that Viva is itself for 70 marks. Okay, first is from the MK part, but it's also given in syllabus. These are the some headings that they have mentioned for the Viva. For example, 20 marks Viva will be there from the Pariksha, Dosha Vikrati, Dhatu, Srotas Vaigunyam, Ama, Nidana Panchika, Kriya Kala, Vyadhi, Vyadhi Shmatva, Dhatu Paka, and our Srotas they have specifically mentioned. For example, अन्नवः स्रोतस् पुरुषवः स्रोतस् प्राणवः मूत्रवः रसवः रक्तवः मेदुवः वातव्याधि स्नायुगत vata and sandhigat vikara. Actually this topic are written very like in a small space, but they are so big topic itself. And next because in the snayugat vata our ardita pakshakata, all those diseases already came. Next from DK portion, some question there from the DK portion, and the DK portion is given rogi and roga bala pariksha, doshagat and roga margam, nidana arthakara roga, vyadhi namakaranam, sadhya sadhata and updrava. Then nice to know there should be no any question. Okay, this is the important point. And then Viva on the activity book, that activity book we have submitted, Viva on that is for 10 marks. Then this is the like instructions given, like there should be open-ended question should be asked relevant, there should be broad conceptualization, linking topic, and avoid leading question, all these things. And the last portion is your internal assessment that you have already, like college already given you. So here our Nidana is over. So many things are there, but last advice is that try to do at least those things that the disease you have studied. For example, RA is very important, so all the clinical sign of RA and all the like differential diagnosis RA, then OA, then ankylosing spondylitis, along with that this ulcerative colitis, and mainly this IBD, then your pneumonia, because the chest X-ray can come, tuberculosis, out of this cardiac disease, this all. Then in psoriasis, so many things are there, special tests are there. And study very nicely locomotor system examination in CNS, because that is very broad and important. And don't forget general examination, okay, because that is very simple and basic but very very important. For example, this lymphadenopathy, edema and all. And in sign, generally they will be giving the sign, the disease we have already studied, because I have given that sign, they are so big because they are from the book, clinical medicine book. And some of the diseases may have we didn't study, for example some neurological study we didn't study, so don't worry, that sign will not come. At least you study the diseases we have studied. For example, this udara, there are some clinical feature for that particular udara, so those things you just focus on that. And for Viva, Viva also, like you have to study your paper 1 and paper 2 content again. All the best. Thank you guys.